Hi, I'm Jeff Todd, President and CEO at Prevent Blindness. Welcome to our Focus on Eye Health Expert Series. Today, I'm excited to welcome Dr. Michael Chiang, Director of the National Eye Institute, to talk about vision research and its role in advancing public health. Thanks for joining me, Dr. Chiang.
Jeff, great to be here, and thank you for the invitation.
Absolutely. So we're hearing a lot about stem cell therapy lately. How can advances in stem cell therapy contribute to improved eye health?
Jeff, great question. Stem cells, if I just step back for a minute, are a type of regenerative medicine. And what the reason that we need that is that diseases often cause cells to die. And so one approach when that happens is that you replace those cells, and stem cells are one way you can replace those dying cells. And so, for example, in a disease like glaucoma, you may want to do this with ganglion cells, or AMD, you may want to do this with photoreceptors or retinal pigment epithelial cells, RPE cells. But there's been a lot of great work in the vision field involving stem cells. Sally Temple, David Gam, who's at the University of Wisconsin, have done some really nice work in diseases like AMD or inherited retinal degenerations with stem cell therapies. And one thing that I'm really proud of, and that I just want to highlight for a minute, if that's okay, is that at the National Eye Institute, Kapil Bharti led a first-in-human clinical trial involving stem cells for dry AMD, in other words, geographic atrophy. And in dry AMD, what Kapil has done is that they've developed methods to take blood from patients and isolate retinal pigment isolate induced pluripotent stem cells. And from those stem cells, they can use them to grow RPE cells, retinal pigment epithelial cells. And they take those individual cells and grow them on scaffolds. And the scaffolds are made of a biodegradable material. They take that material and they've developed surgical methods to transplant that under the eye of people who have dry AMD. Okay, and so why would you want to do that? Because the retinal pigment epithelium disappears in dry AMD, and it's used to nourish the photoreceptor cells. Okay, and so one of the reasons we were so excited about this is that it is the first clinical trial protocol in the US to test transplantation of autologous replacement tissues from patient-derived induced pluripotent stem cells for any disease anywhere in the body. Okay, so and that study basically was the result of over 15 years of basic research and translational research that led to this first-in-human surgery. And that surgery was done during summer of 2022. And the surgeons were Amir Kashani from Johns Hopkins and also Shilpa Kodati. So really excited about a lot of these advances in stem cell therapy.
You just touched on something. I've been talking a lot lately about how innovative research is currently, but so much of that is built on work that's been going on for decades. So that's an important note to mention. Another area that we hear a lot about, and I've heard you speak about so eloquently in the past, is artificial intelligence. How do you see AI being used now and in the future to improve eye care?
Yeah, Jeff, there has been an enormous amount of AI in research and in the general news over the past, especially 5 years. And I would sum it up by saying that AI has enormous potential for helping clinicians do a better job of taking care of patients. There have been studies in many fields of ophthalmology showing that AI can do things as well or better than most experts, even world experts. And that's been done in diseases like diabetic retinopathy, AMD, retinopathy of prematurity. And so that in a lot of cases, the vision field has been really at the forefront, in many cases, really leading any other field of medicine or science in these areas, because we have so much image data coupled with clinical outcome data. And there just aren't a whole lot of fields that have that richness of data. Now, I think that that's everything that AI has done. I think that it would be fair to say that, it would be fair to ask the question, what hasn't it done? And why hasn't it solved all of our problems? And there are a lot of gaps. One of them, clearly, when this pandemic started, AI, the potential was that it was going to solve all of our problems in terms of diagnosing who was at risk for COVID and what people's outcomes were going to be. And it really didn't do those things. There's a lot of gaps in terms of external validation of systems. They may work in one population, but not in another population, that those systems weren't trained in, or with another imaging device, that's different from the one that was used for the original study. And so I think that there's a lot of challenges in terms of potential biases or completeness of data sets. There's obviously work that we've got going on that we're really excited about at the National Eye Institute. Projects like Bridge to AI that are intended to really build large, comprehensive data sets. And one of the things and Bridge to AI is a $130 million project over 4 years. And there are 4 projects supported by them. And one thing that we're really excited about at the NEI is that this is a trans-NIH project, so any field of medicine. And the excitement is that one of those 4 data generation projects is led by a team of ophthalmologists, Aaron Lee and Cecilia Lee at the University of Washington. But ultimately, I think that AI is going to be one of those things that has to move beyond the realm of the nerds into mainstream practice and mainstream education in ophthalmology. And that's going to require collaboration in a really deep way among computer scientists, informaticians, and obviously ophthalmologists and educators. And it's going to require both the people who are on the cutting edge and also the senior people who are managing the programs to really, I think, take this technology and make meaningful change in terms of the way that we improve eye care.
Yeah, absolutely. And you suggested there that eye care and the eye was a little ahead of the curve on this. And another area where I think the eye care was a little upfront was related to telemedicine. But that certainly escalated in COVID when we learned a lot more about telemedicine and how it can be used. Is NEI contributing to the discussions around telemedicine now and into the future?
Absolutely. I'm Jeff, I'm smirking because at the very beginning of my career, I was interested in telemedicine. And I wondered the exact same question: would NEI care about telemedicine? And I wrote to Carl Kupfer, who was the first director of the NEI, who had this position for 30 years, ended up in his office, and I asked him that question. And that's how I started my career, telemedicine for retinopathy of prematurity. So there's, Jeff, as you mentioned, clearly there's, a lot that's been in the background intuitively for telehealth, for ROP, for ophthalmology, because we're a field that's image intensive. And as you alluded to, that just got a lot. It just came to the forefront during this pandemic. And so it's definitely something that we're interested in terms of how to better deliver eye care. And also how to deliver it to eye care that, to people who may not be getting it right now, maybe because they live in medically underserved areas in rural America or urban parts of the country. But I don't see it as being limited to that. In other words, there are plenty of people who would say, if there were an alternative to going to the eye doctors and waiting for 2 hours, and maybe that would be better. So I just a couple examples of projects that are going on. there's a project at the University of Wisconsin that's led by Yao Liu. They're looking at really implementation science. How do we improve access to care by better implementing diabetic retinopathy telehealth screening methods in underserved rural and urban areas. There's, of course, projects involving telehealth and diabetic retinopathy, and the first FDA-approved autonomous AI system in any field of medicine was for diabetic retinopathy. That was Michael Abramoff at the University of Iowa. And they're working, he started a company and they're working on outreach in that area. There's a group at Johns Hopkins that's led by Rissa Wolf, who's actually a pediatric endocrinologist, looking at children with diabetes. And, there's a beautiful project, Audrey Bowen at Vanderbilt University, with a telehealth project integrating OCT with sensors in smartphones to look at glaucoma detection and monitoring. So there's work not only from a technology development perspective, but also from an evaluation perspective, and just really excited to see where it leads.
Well, you kind of alluded to the beginning of your career in ROP and in pediatric ophthalmology. Are there current areas of research in the pediatric realm that you hope come to bear to improve children's vision?
One is refractive error, and I would highlight myopia. It doesn't seem like a hot. You might not think of refractive error as a hot topic, but myopia is reaching epidemic proportions in parts of the world, and the incidence is increasing in the US. And there's good evidence that it's gotten worse during the pandemic. And even in this country and in places, around the world, there's a big problem that kids aren't getting glasses, who should be getting glasses. And in fact, Megan Collins at Johns Hopkins has done some really nice work showing that in implementing a school vision screening program in Baltimore, that kids did better in school when they got eyeglasses. And so, from I guess what I'd call basic science perspective, there are a lot of questions about what are the mechanisms that cause myopia, growth of the eye. And a lot of theories, sunlight, near work, environment, and other screen use. And there's also, as I alluded to here, unclear strategies about how to deliver screening or care at scale. And so one of the things that we've gotten started working with the National Academies of Science, Engineering, and Medicine, NASM, on a report, on a study looking at those issues in myopia. I know that's something that you all are very familiar with. I think another issue I would highlight would be cerebral visual impairment. That's something that's really, we recently completed a strategic planning process, a 5-year strategic plan. And this is one thing that really came to my attention during that process. So we published that plan in November 2021. It was our first NEI strategic plan since 2012 that we've published. And anyway, CVI has become the leading cause of blindness, vision loss in children now. And as a pediatric ophthalmologist, I honestly would often see these patients and feel like I don't have a whole lot to, that I can offer. I just, wouldn't always know what to do or how to manage them. And I think what that boils down to is that we've got a lot of pretty basic questions about how do you diagnose, classify, how do you manage this disease that's going to require a multidisciplinary approach. Another area I'd say is ROP. That's something that I've been interested in throughout my career. But I would say one other area is amblyopia. before I started at the National Eye Institute, I worked for 10 years in Oregon at the Casey Eye Institute, and we had a little Peanuts cartoon on the wall in the back. And it was Linus or Lucy holding an eye patch. And the cartoon said, oh, this has been the standard of care for 100 years. And the patch works well, except when it doesn't. And I would say that our current methods of diagnosis and screening, maybe that's a fair way to say, and treatment work well, except when they don't. And I think that there are opportunities for research that I hope will lead to things like improved screening, improved detection, better understanding of pathophysiology, and better treatments. And maybe that's going to be based on methods like plasticity. So those are a lot of issues, I think, in pediatric ophthalmology.
Yeah, these are all things that we and our National Center for Children's Vision and Eye Health are interested in. And I appreciate the shout out of Megan Collins and her great work. We've been able to tap into her as an advisor to our committee, and she's just doing excellent work there. Here at Prevent Blindness, our primary focus is improving equitable access to eye care. And I know this is a big topic, but what is NEI doing to address health disparities?
This is a really important question. I alluded to our strategic plan, and the way that we organized it is 7 what we called cross-cutting areas of emphasis. And one of our areas of emphasis is what we called public health and health disparities. We've never had anything like that in an NEI strategic plan before. And so I would start out by saying, yes, we are definitely interested in how to incorporate more of this into our portfolio. And I think one of the first steps is just understanding what are these social determinants of eye health? Why are people going blind from treatable disease in 2023? And, there's statistics. We talked about uncorrected refractive error and cataract surgery. And these are things that are very standard in terms of eye care these days. But we have a statistic that if you're a Black person in the US compared to a white person in the US, you are 15% less likely to get cataract surgery. And obviously, when care is provided, there's good evidence that outcomes aren't the same. When you look at different populations, and I think those are big challenges. And one of the things that we've tried to do is partner with other organizations. And one of them is NIMHD, the National Institutes of Minority Health and Health Disparities at the NIH. And we've been working with them to try to plan a workshop on better understanding what these challenges are and how to address them. And Jimmy Lay is one of our program officers who's been leading from our end to plan this workshop. And there's a couple goals. One of them is to look at approaches toward addressing disparities for very specific problems. It's those things I talked about before: unoperated cataract and uncorrected refractive error. And we're also looking at potentially broadening that to glaucoma and diabetic retinopathy management. And another goal of the workshop is basically to look at what are some scientific approaches that we should be taking toward better understanding the underlying basis for health disparities in eye care and vision care, and with the premise that if we better understand it, we can know how to target those research projects in the future. I think that clearly one of the other things that actually I should say one of the other partnerships that we've gotten into is working with a trans NIH project called Compass. It's a so-called common fund project. It goes across all of NIH, and it's almost $400 million over 10 years, looking at community partnerships in healthcare, and basically looking at structural interventions to address these social determinants that can change, that can really constrain health behaviors and health outcomes. And lastly, I would say that one of the things that we've really gotten interested in is trying to build a more diverse workforce. And just to highlight one project that we worked on, two of our folks at NEI, Davina Fan and Maria Zacharias, led a project that was called Eye on the Future. And the basically a video contest for high school students to try to get them interested in vision. And just we want to build our workforce basically. And we targeted it toward high school students from underrepresented backgrounds in science and medicine. And for the 10 winners, basically brought them to NEI for a day and toured them around, had them meet some of the scientists, do dissections, and get to meet people. And we actually had two fantastic young clinician scientists who are working in health disparities. One was Kristen Wanyuwu, who's from Yale, and one's Angela Elam, who's from the University of Michigan. And they spoke beautifully, and I thought were really inspirational to these, the students who were visiting. And ultimately, I think there's a lot that we'll need to do. But these are some of the things that we've been trying to do to move the field along.
I actually just spoke with Dr. Wanyuwu on one of these videos a couple weeks ago. She's terrific. Well, this is really great work you're doing, and we were so impressed with the strategic plan and that you actually did include public health and health disparities. So big kudos to NEI for doing that. Before we wrap up, do you have any final thoughts you'd like to leave related to research and public health?
One of the things we strive to receive in doing these plans is getting public comment. And I appreciated your comments about our strategic plan. Final comments. I would say, number one, I finished my clinical training in 2001, and now is 2023, so it's been 22 years. I would say that if I look back just within my career, there are treatments available today for disease that were not available when I started my practice. And just to give two examples, one is inherited retinal degenerations. Within the first year of my practice, I diagnosed a baby with Leber congenital amaurosis. There was no treatment in 2001. And there is a treatment for certain types of mutations that is available now because of gene therapy. And I never would have believed that would be feasible in 2001. Another is ROP, that I took care of babies at the beginning of my career who I really believe who would have had better vision if they were born in 2023. And I'm really proud that those advances were because of, in large part, NEI funded research. I think another thing I would end with would be to say that just having spent a large part of my career teaching young people, teaching younger people, I often would be faced with the question, why should I care about research if what I want to do is grow up and take care of people rather than discover new things and write papers? And I struggled with a long time to try to find a good answer, for that. But I think that what it really, after thinking about this for about 10 years, the best that I can come up with was that on the first day of medical school, students are told, often within the first 15 minutes of the first day, that half of what you learn in your career, in half of what you learn during the 4 years of medical school is going to become obsolete within your clinical practice. And I never believed that on the first day, but it's absolutely true. And as a resident, I learned about things like the MPS, the macular photocoagulation study. And this I finished in 2001. And within 5 to 10 years of finishing, that became totally obsolete because of anti-VEGF. And so that was a huge part of my medical retina education, completely wiped out. And so to me, that's why research matters, because the standard of care evolves, and we're always coming up with ways to do things better. And to be able to give the best care to patients, doctors need to understand how new knowledge gets generated. And that's what drives clinical care, and that's what drives public health. And Jeff, the last thing I would end on is something that that was the foundation of one of your questions. That a lot has happened because of this pandemic, and I would say that this is obvious, but this pandemic exposed a lot of inequities in this country, and the best science that we can do isn't nearly as useful if it's not accessible to people, especially if it's not accessible to people who need it the most. So I think that we've got a lot of work to do in science and clinical care, and we've also got a lot of work to do in terms of addressing these gaps in public health and just in health equity.
I think that's so true. I mean, ultimately, the best way to measure a community's or a country's public health is by measuring the health of those who have the least access. And so that's what public health to me is really all about. Well, thank you, Dr. Chiang. Really appreciated the time today. Thanks for joining us.
Thank you very much for having me here, Jeff.